All right, radiology. Radiology. Well, it depends on what you're doing. So with radiology, a radiologist is what? Someone who specializes in radiology. They are still considered a doctor of medicine, but it is radiology. Radiology is the branch of medicine that uses radiant energy to diagnose and treat patients. Underneath your radiology subsections in your CPT book, right, we start off with diagnostic radiology, right there in green, and in parentheses it tells you in your CPT book, diagnostic imaging. Now if you notice, you have some white space before it, and you have some guidelines. So if you have a section in your book where you have body planes, I think in the beginning of your CPT book you have body planes. Just remember where they are. If you're not familiar with anterior, posterior, that type of stuff, just make a note where to find it. Then another subsection you'll have is diagnostic ultrasound. Also, radiologic guidance, breast and mammography, bone and joint studies, radiation oncology, and nuclear medicine. These are all subsections. One of the big terms in radiology is fluoroscopy. In fluoroscopy, we actually view four sides of the body. It can also view the inside of the body, and what it does is it projects onto a television screen. So with fluoroscopy, we have live images by which the physician can view the function and structure of an organ. So if you were to look at code 71034 in your CPT book, 71034, you'll notice it's a chest x-ray with fluoroscopy. (71034) 71034. Also, in your book, you might want to make a note right above radiology. Modifier 26. So right above radiology, modifier 26, and RT and LT. Modifier 26, LT, and RT. You use these most often. But keep in mind, if they're already in the code descriptor, you shouldn't need them. And if the report says right and left, you shouldn't really need them. Anything that comes or gets sent out with a report, usually if it reads right or left or bilateral, you don't always need the modifier. You're going to have to know what the payer wants. That's honestly and truly what it comes down to. Anthem might want RT and LT, even if it's in the report. Cigna might not care. You just need to know which insurance, which payer wants what.
So would it be best just to always put it there?
With your RT and LT, you can't always go wrong, but you want to be very careful with some other coding and modifiers that if it's not needed, don't put it, okay?
Yeah.
Your 26 modifier is the professional component. Your TC modifier is the technical component. Your professional component is normally included. It will say in the descriptor, supervision and interpretation included, something along that line. An MRI is a magnetic resonance imaging. It uses magnetic energy to view the soft tissue structures. MRI should be code 70326 or 70336 on page 394, right-hand column, an MRI. (70336) MRI. Pay attention also to modifier 52. Modifier 52 is used if they do fewer than the total view. So if they do 3 views instead of 4 views, you would use a modifier 52. You see on page 776 in your textbook, 776 in your textbook, they go over the different planes with you and positions for radiology. On code 70373, code 70373 in your CPT book, you want to put in parentheses that this is global. This would be part in a global period.
70373, right?
Yep. 70450. 70450. A computed tomography is a CT scan. Computed tomography is a CT scan. On 70460, when it says with contrast material, the injection is built in. 70460, injection is built in. Figure 2812 in your book, 782, I believe, figure 2812. Figure 2812 in your textbook is magnetic resonance angiography. This is it where an MRI provides visualization of the blood flow in the brain. All right, code 72010 in your CPT book. Right above that you have spine and pelvis. Right next to spine and pelvis, you can make a note that says orally or rectally.
Can you repeat that?
Yes. Right next to spine and pelvis, write orally or rectally. Code 72170. 72170 is the frog position. 72170 is considered the frog position. And it can be bilateral. You're squatted like a frog.
So they say right or left or bilateral or?
Because they might have you squat in that position and only do the right side. I don't know why, but could be. 72285. Let me see here. Let me make sure. 72285 through 72295. Put some brackets like this. 72285 through 72295. Put some a bracket there. And what you want to write next to that bracket is to check for injection codes. We talked about the planes of the body, position and projection. The position is going to be the way in which the patient is placed. The projection is going to be the path the X-ray beam travels. Terminology, again, radiology is going to use a wide variety of terms and abbreviations that are specific to planes, positions, and projections. You have component coding, which I mentioned a little bit about earlier. There's 3 component terms that you need to be aware of: professional, technical, and global. The professional component is the modifier 26 that I talked to you about. This is the physician portion of the service. What this includes is the supervision of the technician and the interpretation of the results and writing, including the written report. So you have a professional component, which is modifier 26. It's the supervision of the technician, the interpretation of the results, and the written report.
Okay. So you put the TC for the technical component?
When it's applicable.
So if somebody else is doing the actual thing, that's taking it. Kind of, I get stuck on that. So 26, I know it's supervision and interpretation, but shouldn't they all have supervision, interpretation, and a technical component? Because does the doctor actually run the machine himself? Or?
It's quite possible. If you have a physician practice where they have an X-ray machine in the office and they're licensed to take the X-rays in that practice, the doctor is doing the technical component and the professional component. He does not have a technician.
So there's no, in that case, there would be no modifier.
In that case, he could use the 26 and the TC modifier, or no modifiers at all because he is recognized as an office, not a facility. In a facility, you have a technician who you would append the TC modifier to the code, and you would have a 26 modifier to the actual report part of it. So 72100 in an office setting, you could use 26 TC, where the doctor took the x-rays and also did the professional component. Now, if the doctor took the x-ray and sent it out to be read somewhere else, he would not do the 26 modifier, he would just do the TC modifier. And then the doctor who he sent it out to could do the 26 modifier.
Do they both fill the same code?
Yep.
Then that would be vice versa, correct? If the doctor took the actual thing and sent it to, no.
Oh my gosh.
If they send a person out to another facility.
If they sent the person to the hospital, and the hospital in turn sent the x-rays back for the doctor, he could charge the 26 modifier.
And they would charge the TC?
Yes. But most of your facilities, because of the place of service code, don't always have to use a modifier.
So it's the hands-on person that actually presses the buttons and the screws.
That's the technical.
TC,
Okay. Professional 26, supervision of technician, interpretation of report, and what was the third one?
Didn't get there yet.
Oh, okay.
Those are the only two things for a professional component.
Oh, okay. Okay.
Yep. Yes, Rayanne.
It explains it pretty well for them if they're confused on page 778. Everything you were just saying.
Excellent. 778 in your textbook.
Yeah, I had it highlighted too, it just didn't stick.
Okay, can I just ask you, okay, a doctor, and we have the facility, like, say, next door, and we can send people over to get x-rays. So our doctor says, okay, I think you need a back x-ray, looks like you have a slip disc or whatever. We send them over. That person does the whole x-ray, which is a tech, but then he doesn't interpret the x-ray because a radiologist really should interpret the x-ray. So he is getting a TC? Okay.
Yep.
And then the other person, which could be like a consultant person that comes in and reads
Yeah,
the
most of
x-ray?
your radiologists now are consultants.
Right, they aren't on staff, so they're doing a separate billing
Right.
for their reading of
And they do
the
a
x-ray.
26 modifier.
And they do the 26, okay.
What they don't tell you with radiology, especially the 26 and the TC components or modifiers, is that's a very gray area also, because it also depends on your place of service. Is your place of service recognized to build that code? And if so, you don't necessarily need the modifiers. Again, it depends on what's your payer looking for. And the only way we find out sometimes is when they deny it for invalid or non-existent modifier.
See, that was another thing I remember they were having on Express Care, because that comes back, and before the patient can leave, that doctor actually reads it, but it's not the real reading.
What happens is the doctor takes a look at it just to make sure that there's nothing there to warrant admission to the hospital or surgery, because they're covering their butt by doing that. Because if you wait till that x-ray gets sent over to someone for, let's say, a wet read, an emergency reading, it could be anywhere from an hour to 24 hours. I mean, with teleradiology today, you can send a file over to a radiologist within minutes. but it's a matter of urgency, because then you're coding for the emergent reading of that. And, back in the old days, right, you would go sit in the waiting room until the radiologist could take a look at it and say, they're okay to go. But nowadays, the doctor has just enough knowledge to look at that x-ray film and say, okay, wait, they can go. And then they send it off to be read.
But that shouldn't be a charge for
No.
that?
No.
Okay.
No.
Do you know what an easy read is?
A wet read, quick and easy read. Basically, it's the physician going in, having enough knowledge just to say, okay, admit or leave. One of the two, or they need surgery, or let's get them over to a neurosurgeon, or they need a neurologist. That's what they're doing when they do an easy read, or a quick read, or a wet read. Okay? So then the second component is the technical component. And this is the technologist services. This is the equipment. This is the film. This is the supplies. And then we have the third component, which is the global procedure. This is where you have both the professional and technical portions of radiology service. So if the facility where the procedure was performed owns the equipment and has a radiologist on staff who reads the report, this is your global service. So with your express care, you might send them right across the street to the imaging place. So that imaging place just takes the x-ray and then it gets sent out elsewhere. That would not be considered global.
Right.
So if my prime care physicians practice, I know they do x-rays there, but they send the x-ray off to the hospital to be read. So only the chiropractic, one of the chiropractors that I work with, he will read his x-rays and take his x-rays. That would be the global component.
So if they do both,
That's the global. So you don't need the TC or the 26.
like our facilities have x-rays there with the express cares, and we send like the clinic part. We send the patient, I'm gonna send you down an x-ray. So that would just be, and then the x-ray is then read at the hospital.
Right.
Okay.
Yep. So just pay attention to the modifiers that you need on each component. So professional is 26, technical is TC, and the global you don't have any. Now, when you read the descriptors underneath the professional component, that is your supervision and your report. Your technical component, again, the technician, the supplies, and the equipment. Let's take a look at code 71030. 71030. When you read that code, tell me what it is. What component is it?
It's just a TC.
71030. Read it to me.
Radiologic examination, chest complete, minimum of 4 views. So someone's taking it, the x-ray. Is it?
It's global. It's both the professional and the technical component.
Holy crap.
Is that because of the
Where did you get the global?
examination?
Because
No,
the
because the
complete
exam.
exam.
Okay, I was thinking of that, but,
Yeah.
so I must have cooked some of my stuff.
So your third-party payers will usually reimburse 40% for the professional component, 60% for the technical component, and 100% for the global procedure. Again, I mentioned it earlier, when they say with contrast, that implies that the injection is built into the code, okay? So you will not code the injection separately.
So underneath that 71030 is the 71034 with fluoroscopy.
Right.
So that's,
That doesn't say contrast.
oh no, it doesn't.
It says with fluoroscopy.
Mhm.
So let's take a look at 75893. Code 75893. Take a look at that for me. Lori, read it to me, please.
Venous sampling through catheter with or without angiography, e.g. for parathyroid hormone, renin, did I say that right?
Mm-hmm.
Radiological supervision and interpretation for procedure use 36500.
Perfect. So when you look at some of these codes, it's also going to tell you for the procedure, it will have parenthetical notes that move you forward, okay? Because it's telling you, yes, this is the sampling, but for the actual procedure, use code 36500. So they're using contrast material to obtain a sampling, which is the 75893, but the actual procedure code would be using 36500. Oral or rectal contrast does not qualify for with contrast. Oral or rectal contrast does not qualify for with contrast.
One more time.
Oral or rectal contrast does not mean with contrast. So diagnostic radiology. For diagnostic radiology, when they talk about complete in the code descriptor, all right, we're still in that section of diagnostic radiology, which starts on page 394 in your CPT book. When they talk about complete in your code description in the radiology section, they mean that all views are taken of the specified body site. When it says complete, so that radiology exam complete views, that means they took all 4 views. Okay? This is one of the most standard radiographic procedures, and the codes are often divided on whether or not contrast material is used. Then your codes will be further divided on the number of views. So it will say with or without contrast, then it will probably say 1 to 2 views, or 3 to 4 views, or
Here's one. Code 70250 is radiological examination, skull, less than 4 views. And under it, 70260 is complete, minimum of 4 views.
yes. So one will have 4 views and one will have 3 views. Diagnostic radiology is also used to diagnose disease and monitor the disease process. Is it progressing or is it in remission? We have either X-ray, CT or CT scan, magnetic resonance imaging or MRI, and angiography. Those are the diagnostic procedures that you would see underneath diagnostic radiology. When they talk about a computerized axial tomography, this is where the X-ray image is taken in sections. So they might take the brain, and you have an example of it in your textbook, and just take it by different slices, different angles. That's what a computerized axial tomography is. The computer actually reconstructs the image of the brain for you. MRIs, this is the magnetic fields are used to produce an image that's displayed on a computer screen, as we've seen. Your codes are going to be of the same area, such as we saw in the spine section. And these, again, are going to be divided on whether or not contrast material is used. So for radiology, make sure you see complete, number of views, with or without contrast. Those are the things I would be looking for to highlight when I'm in this section. When we talk about angiography, this is actually used to view the vessel obstructions, and this is where they actually inject dye into the vessels. Figure 28.13 in your textbook is a pretty good picture. My book is 783, so figure 28.13 is angiography of the aortic arch and the brachiocephalic vessel. Radiologists use angiography to diagnose vascular conditions such as malformations, strokes, and myocardial infarctions. So what you want to remember, as I wrote on the board, if it is less than a total number of views, use modifier 52, which indicates a reduced service. Diagnostic ultrasound. On page 412 in your CPT book, diagnostic ultrasound.
Dorian, I have a question.
Yes.
So would you use modifier 52 on a code like 70250?
What's the one you said was available? Because of the examination.
No, that was on 70373. On 70250, skull less than 4 views.
I think Celeste,
Probably.
Didn't
Thank you.
Celeste if that was the examination?
No, she asked on another code.
70250.
It was like 71 something. It was 71020 that she asked that question on.
So
Yeah.
70250.
Well, 7103.
71020.
So 70250
So yeah,
does get a modifier?
70250 could possibly use a modifier 52. Diagnostic ultrasound, page 412 in your CPT book. Page 784 in your textbook. Diagnostic ultrasound is using high-frequency sound waves to image anatomic structures. this is where an audible sound bounces off the body tissues and then they're recorded to give information about the anatomy of the internal organ. So you can see gallstones. You can see, twins, fetuses, different other things going on. Some of your subheadings underneath diagnostic ultrasound are primarily based on the anatomy. So you'll see head and neck, chest, pelvis. There are a lot of notes in this subsection that direct you to coding the correct assignment. You actually have 3 locations for ultrasound services. You might find ultrasound services located in radiology underneath the diagnostic ultrasound services. You might find it also in the medicine study, in the medicine codes under your vascular studies, or under medicine codes for echocardiography. So you can find ultrasound services in 3 locations: radiology, and vascular studies, and echocardiography. And the last 2 you will find are in medicine codes.
And
Echocardiography.
medicine.
Yes. An interventional radiologist is a combination of a radiologist and a surgeon. They provide the total procedure for a cystography with contrast. That would be code 74430. That's the X-ray portion of it. So 74430. Code 74430 on page 403 in your CPT book is the cystography with contrast. That's the X-ray portion. Then for the injection procedure, you would use code 51600. And you notice right there 74430 says radiological supervision and interpretation. You don't need the modifier because it says it.
So where does it tell you?
So if it says radiological supervision and interpretation,
You
then
don't
you don't
need
need
the
the modifier. Okay.
Where does it say it was with contrast? You need an injection code because it has contrast, right?
Right.
What was the code?
74430.
Huh? Sister.
Cystography.
Okay.
Yep. Minimum of 3 views, radiological supervision and interpretation.
Mm-hmm.
So then the injection procedure would be 51600. And then any supply code for the contrast material, you would use a HCPCS code. You might use the HCPCS code for the actual material or the 99070.
Was that 99070?
Yes.
That's for the supplies?
Yes, it could be that or the applicable HCPCS code, yes. Then we have ultrasound modes and scans. Ultrasound modes and scans. All right, underneath diagnostic radiology, diagnostic ultrasound on page 413 in your CPT book, 413 in your CPT book. It has notes about the ultrasound modes and scans. It tells you what is an A mode, what is an M mode, what is a B scan, what's a real-time scan, and what's an A and B scan. Your A and B should be medically necessity documented. So page 413 in your CPT book, it tells you about the ultrasound modes and scans. It gives you the definitions, what each one is.
So A and B, medical necessity.
Yep, medical necessity. Yep. Remember, again, if they talk about a complete scan, they're talking about the entire body. If they're talking about a limited scan, they're talking about parts of the body or a part of the body. If they're talking about follow-up and repeat, then it's a limited study that was previously scanned already.
Sorry.
Nope, I think that was mine. Okay, radiological guidance, breast mammography, bone and joint studies, radiation oncology. So radiological guidance, page 417 in your CPD book, 417 in your CPT book, radiologic guidance. This is fluoroscopic, computed tomography, magnetic resonance, and other stuff. And it tells you right in the beginning in parenthetical note, do not report guidance codes 77001 and so on for services in which fluoroscopic guidance is included in the descriptor. Your breast mammography codes, this would be stuff such as screenings and computer-aided detection. That's on page 419 in your CPT book. Your breast mammography codes, screenings and computer-aided detection. Your bone and joint studies on page 419 in your CPT book. This is such as bone density and joint survey. So your bone and joint studies on page 419 in your CPT book. Bone density and joint survey. Radiation oncology. Page 420 in your CPT book. Radiation oncology, you're going to see therapeutic use of radiation. You will see codes for both the professional and technical services. And pay attention to your subheadings because these will be divided based on treatment. Your subheadings are based on treatment. On page 420 in your CPT book, at the top of the right-hand column, it clearly tells you preliminary consultation, evaluation of patient prior to decision to treat, or full medical care in addition to treatment management when provided by the therapeutic radiologist may be identified by the appropriate procedure codes from your E&M medicine or surgery sections. You want to pay attention to where is this going to fall, because if it's an outpatient, it's going to come under your 99241 through 99245 codes. If it's an inpatient, it's going to fall under your 99251 through 99255 codes. Okay? Your follow-up consultation criteria, you want to document who and why. The clinical treatment planning, still on page 420 in your CPT book. This will include the interpretation of the special testing. It tells you right there in the first paragraph. It includes the tumor localization, as well as the determination of treatment volume. It will also include the choice of treatment method, the determination of number of treatment ports, the selection of the treatment devices, and any other necessary procedures. Your clinical treatment planning consists of 3 types of plans, and for all patients that require radiation therapy. You'll see simple, intermediate, and complex. It goes into the different explanations and what they mean. And as always, we have an unlisted procedure code, and that always requires documentation. That would be code 77299. The simulation codes 77280 through 77293. These determine the placement of the treatment area and the ports for radiation treatment. They do not include the administration of the radiation, and it tells you right there in the paragraph.
So the administration is separate.
Yes. The next subheading is medical radiation physics, dosimetry, treatment devices, and special services, right on page 421 in your CPT book. The decision-making services of the physicians. You will see here the treatment types, the dose calculation and placement, also known as the dosimetry, and the development of the treatment device. And you'll see that in throughout the codes here. Over on the next page, 422 in your CPT book, the stereotactic radiation treatment delivery. Pay close attention to your notes. You only have 3 codes here, but pay attention to the notes. You have a couple parenthetical notes. The radiation treatment delivery, it delivers a large dose to a specific tumor site. Over on the right-hand column, radiation treatment delivery. You have radiation itself. The codes range from 77401 through 77421. Then you have the neutron beam, which is 77422 and 77423. And then you have the technical component of the actual delivery of the radiation, and that's broken into the electrons, the neutrons, and the protons. You'll also see in these codes it talks about the amount of the radiation delivered and the type of radiation. The electron is the most common type of radiation. So it will tell you right in the code. What you need to know when you're coding radiation treatment delivery all right, is what are the number of areas that are treated? What are the number of ports involved? And how many blocks are used? So for radiation treatment delivery, you want to know what number of areas are treated, how many ports are involved, and how many blocks are used. And it will tell you right in the code, radiation treatment delivery superficial and or ortho voltage. Radiation treatment delivery single treatment area, single port or parallel opposed ports, simple blocks or no blocks, up to 5 MeVs. So it does tell you in the code. Over on page 423 in your CPT book, reporting radiation treatment management. This is the professional portion of the services. And you'll see in the paragraphs, it tells you that this will include the review of the port films. It will review the dosimetry, the dose delivery, the treatment parameters, the treatment setup. It's all right there at the bottom of the paragraph. So radiation treatment management, all right there. This is the professional portion of the services, and it tells you what it includes. Clinical brachytherapy, you actually have an example of that in your book. On page 425 in your CPT book, clinical brachytherapy. This is the placement of radioactive material into or around the site of the tumor. It can either be intracavitary or interstitial. Intracavitary is within the body cavity. Interstitial is within the tissues. So the source is the radioactive element. It is delivered or delivering radiation dose over time. Some of the references will be either to seeds, ribbons, or capsules. Ribbons are seeds that are embedded on the tape. The tape is cut to desired lengths, and it controls the amount of radiation that's inserted into a tissue. Your clinical brachytherapy codes are divided based on the number of sources that are applied. Is it simple? Is it intermediate? Or is it complex? They give you a definition in the CPT book. Your nuclear medicine over on the right-hand column. The nuclear medicine talks about placement of the radioactive material into the body and the measurement of the emissions. This is going to be used for both diagnostic and treatment. So a good example would be a stress test. Your codes underneath nuclear medicine are divided primarily on the organ system. So is it therapeutic? If it is therapeutic, if it's listed as therapeutic, that would be an exception, because if it's listed as therapeutic, that would be for radiopharmaceutical therapies. So again, nuclear medicine, the codes are divided primarily on the organ system. And that's it for radiology. Love it, right?
No.
All right, theory and practical at the end of 28.
Can I go to the bathroom, please?
Absolutely.
That I was pulling my hair out.
I know. This radiology is really just like,
People just mentioned.
I jumped over and did lab. Then I went back
No, I
to
think it was
radiology.
happening.
I had to.
Did those run okay?
We don't have a conference call this Thursday.
I don't know.
Told me we don't. Chapt sent us another report, DNF report,
Oh, I didn't know.
and it's not in order. You know what I mean?
Oh, it's all like different departments all over
Yeah,
the place?
all over the place. It's like trying to put it together. So you have to look through.
I was trying to Did you ever I couldn't get into my Meditech at home. I was trying to look at, because I have quite a few of those codes I have to check.
Yeah, I wrote some down. Tomorrow I'll do some. Each day I told Rita, I said, I mean, I'm not gonna get this done today. She goes, no, just work on a few at a time.
That's what I'm gonna do.
You know, I don't have, one day I didn't have any.
Okay. We're in the registry cleaner that hadn't been done for a while.
CC?
Yeah.
Yeah, I did.
Okay,
I'm running
it was
regularly.
full.
What's the register?
Yeah, what is
But every
that?
time I run it, it says it's full.
Okay,
And then I run it again and
So
am I
try
running
it.
wrong?
try it. I don't know. Just try it. See if it makes a difference.
Okay.
What's a register cleaner?
It goes in and it cleans out your cache and cookies and stuff. That whenever you go to a website, it always downloads a bunch of
Right.
cache and cookies. So if you go in and clean out your registry, and it takes it out of there. Because when it sits there, it remembers it.
Yeah, and then it pulls some crap and you see it.
Yep.
Huh.
Yeah, that was free too.
It's called CC?
Mm-hmm.
All right, theory and practical. I'm sure work has you do certain ones to clean up your systems.
Work probably does.
Yeah, they probably do it internally.
All right, chapter theory and practical in your textbook. Number 1, radiology.
Well, I got that one.
Number 2, diagnostic ultrasound and radiation oncology. Number 3, separate procedure. Number 4, 100. 5, modifier 26. 6, supervision and interpretation. 7, diagnostic ultrasound or echography. 8, type. 9, physics. 10, dosimetry.
What was 9?
Physics. 10, dosimetry. 11, energy.
Oh, I put that calculation, that's not right, it's dosimetry.
Right.
11?
Energy.
Oh, man.
12, mega electron volt.
Yes.
That one's right.
13, 5.
That one, right.
14, tracer. 15, median. 16, horizontal or transverse. And 17, frontal.
Oh, that looked like dorsal, where they were pointing.
Number 19. CPT code, number 18. CPT code 99212 71020 99244 71250 modifier 26.
What was that? 712?
1250 modifier 26. And 31628.
Almost.
19. 99202
Yes.
70134 69433 with diagnosis 388.70. 20. 99205 with diagnosis 782.3.
You don't want to write her left there.
No. 21A, 75801 with 729.81 and V10.3.
V10.3?
V10.3. 21B, 38790, 729.81, and V10.3.
Because it's the same thing.
Yeah,
What was it, V what?
10.3. All right, workbook, page 179.
Is, you had number 18, and it was like, it was like the third part of it. Was that the,
E&M consult.
okay, all right. I changed it because I talked to you.
Don't listen to me.
I go,
And you're like, no, I told you.
179 in your workbook. 2 is E. 2 is E. 4 is F. 6 is D. 8E. 10C. 12D. 14D. 16B. 18A. 20G. And 22F. 24, 92974. 26,
What was that?
24, 92974.
I don't know how you got that. I couldn't figure that out at all.
What is the add-on code for coronary artery TANS catheter placement during coronary intravascular brachytherapy for delivery of radiation device? I'm going to start with coronary artery placement.
Okay, so would it be placement first?
Coronary artery.
It would be under coronary.
Well, I gotta do that. I didn't mention it. It's in a different set. It's medicine. There's a coronary arteries.
Would it be under, okay, coronary
Then go to
artery
placement.
And then placement? Oh. Okay. Radiation delivery service?
Yep.
Oh, I saw that, but I'm like, that doesn't look right, so I didn't even look the code up.
There you go.
Okay.
All right, 26 is the modifier TC. (28) 70030. 30 71100. 32 72128. 34 73110.
Okay, I'm sorry, can you go back? Oh, maybe 28, what was that?
70030. 36 is 99213. and 70460.
Repeat that again.
36 99213 70460.
Would that have the TC on it?
No.
So the 99213 should have been first.
Yes.
I had it reversed.
I did too because it said radiologist on the other side.
But then. I
Right,
think-
oh, okay, I see
Yeah,
now.
now
Okay,
after
I see.
class,
Right,
now I
yeah.
understand it.
Right, and the patient has to be seen first.
Yeah.
Right, the clinical radiologist performed the x-ray.
All right, 38 99242 and 70492. 38 99242 70492.
I had 7. I had 91 and 90. I wouldn't. Never mind.
Number 40 73600. 42 75741. 44 77011. 46 72110. 48 77057. 50 70328. 52 74340. 54 76390 with diagnosis 225.2. 54 is 76390 with diagnosis 225.2. 56 75820 with 585.6 and V45.11. So 56 is 75820, diagnosis 585.6 and V45.11.
That's for the hemodialysis to be filled, right?
Yes. Number 58, 76819 with a modifier 26 and a diagnosis of 642.93.
That's for 58?
458.
Now, what page is that report on?
78690.
76819 with modifier 26, 64293. 60, 70544, modifier 26 with 378.52.
I'm sorry, can you read that again?
60, 70544, modifier 26 with diagnosis 378.52. 62, 73620. Now you could have had it one of two ways. 73620, modifier 26 with an LT, or 73620 with a modifier 26. Then your diagnosis is 729.5. 64, 78582, modifier 26 with a 786.05.
I made a little note. How the bleep do we tell from these reports to use 26? I because there were a couple of odd numbers that the answer was 26 and I didn't have enough. I'm looking for an indication that there's the wording says received in container for tissue. Are you supposed to assume that's a technician talking? No, that's what I mean. It says professional.
The professional component for the last one we just did, the pulmonary ventilation and perfusion imaging, it's just knowing what part does the technician do and what part does the radiologist do. So the professional component, the supervision, and the radiologist needs to be in there during that type of procedure. So that would be your supervision, and then the interpretation is the report. Take a quick stretch break and we'll go into Path and Lab. Question?
Well, it's about one of the physicians went in and did a biopsy of, it's the first time I've ever seen him do a biopsy. She was having some abnormal bleeding and stuff, and he did it in there, and he coded it. I looked up the code, and it was correct stuff, but he coded it out. It was a biopsy, and he just did it. So I sent it back saying, I'm holding this until the path comes back. Was I correct in doing that?
Well, the biopsy might have been included in the code.
Oh, okay. I don't remember.
And then you were going to send me last week another.
Oh, yeah, and I couldn't find it.
Okay. Okay.
The next time I'll write it down exactly.
Yeah.
But, yeah, I went back.
I would look up the code. It might be included.
Okay.
The biopsy could be included. Was it an OBGYN visit?
No, not really.
Okay.
He just came in for breakthrough bleeding after a year, and stuff. I don't know. But with him, I have to be careful.
Right.
Because he just sends them out,
and
then he'll tell me later, we need to change his code.
Mm-hmm.
Yeah.
Yeah.
So I hold all his,
Yeah.
anyways. But I like to let him know I'm holding.
Yeah, this is money going out the door because you haven't.
Right. And guess who that is?
What's his face, the little guy?
Yeah. The
Now,
leprechaun.
that report, 46, this is a biophysical profile. And then the diagnosis says pre-eclampsia. Yeah, pre-eclampsia or eclampsia, superimposed or pre-existing hypertension.
Mm-hmm.
I guess what I did is I just coded it with hypertension. But it doesn't say, how can I get pre-eclampsia from this? I mean, I saw that she had nodulars, because the hypo, how do you pronounce that? Hypoechoic?
Hypoechoic.
I killed it. Hypoechoic was in the uterine. So she had some of those, but they were presumed.
Okay, so are you looking at the diagnosis or the CPT? Which?
Well, no. How did you get the diagnosis from that?
High blood pressure and the heart rate.
From the clinical symptoms?
Yep.
Okay. I don't know if I would have gone.
Well, high blood pressure was complicating the pregnancy.
Right, and that's why they did that.
Yeah.
But I can't tell from this information if it's preeclampsia. I couldn't tell.
And that wasn't really the issue. It was just knowing the patient's presenting with high blood pressure.
Okay, because I just coded it with high blood pressure.
Yeah. So hypertension, complicating the pregnancy.
Okay, all right. And also, I put, it said should it have a stress test, or was it without a stress test? Is that considered a stress test because of the high blood pressure?
Well, not necessarily. It was fetal testing.
Considered.
Fetal testing.
Okay.
Yeah.
All right. Okay.
So the mother presented with hypertension because and she was pregnant, so it was complicating the pregnancy. So they wanted to make sure the baby was okay. So they did the fetal testing.
Okay. Got it.
So it was 642.9, unspecified hypertension.
642.93.
Or you would call it gestational hypertension, which is what I did, 642.3.
Okay, look at those two codes and tell me why it's not 642.3.
One says transient, and one says unspecified.
I didn't have much of a social life. I haven't talked to them.
Only thing I see is.
In this case, it's complicating the pregnancy. And 642.3, it's telling you that it's transient hypertension of pregnancy. The patient presented with the high blood pressure, which is a complication to the pregnancy. So 642.93 is the unspecified hypertension. We don't know why she has the hypertension, but in this instance, it's complicating the pregnancy. So whenever you're questioning why, what code versus what you chose, you really need to look at the fine line, the numbers in between, the hidden message, because that is what determines why this one is right and this one is incorrect. And it's not necessarily wrong, it just is not the most accurate for this specific situation.
Okay.
Because it's all about level of specificity, level of detail. So in this instant, this patient was presenting with high blood pressure and she was pregnant. They didn't tell us what the high blood pressure was from. We all know high blood pressure is hypertension, so it's unspecified hypertension complicating the pregnancy. So then they tested the baby to make sure that the baby was correct and nothing was wrong with it, not in distress or anything. So we're coding the fetal testing. How did they do it? They did it by ultrasound, and then we diagnosed the mother with having hypertension, unspecified hypertension. All right, path and lab. Path and lab. You're going to see a lot of subsections here under path and lab. And our subsections are all in green. So the first subsection is organ or disease-oriented panels on page 450 in your CPT book. What you want to know with path and lab is you will use modifiers 90 and 91. So for path and lab, modifiers 90 and 91. Path and lab, you will use modifiers 90 and 91. You will see drug testing, therapeutic drug assays, evocative and suppression testing, consultations, urinalysis, molecular pathology, chemistry, hematology and coagulation, immunology, transfusion medicine. These are just a whole list of subsections you're going to see underneath path and lab. So your codes for laboratory testing only. Your specimen collections are coded separately. How is a specimen collected? If we have a venous blood draw, what kind of collection is that?
Blood.
It's a venipuncture.
Yeah.
Okay? A venipuncture. Your Medicare fee schedule each year will identify the lab tests that are associated with the physician component. So if you specialize in path and lab, then that's going to be the report you're going to be looking for every year. You also want to pay attention to your facility indicators. This allows additional tests without the physician written order. So for example, if a urinalysis is positive for a bacteria, then there will be a built-in indicator to also culture it and decode for that culture. Okay? So the lab will already know if it comes back positive, they're going to run another test to culture it. What type of bacteria? So it doesn't have to come back to the physician and the physician says, now I need to know what type of bacteria. Okay? It's that kind of all-in-one thing, and it's that get out of jail card. So if you see this, you are allowed to do this type of thing. With the path and lab, you want to be very careful that you do not, how do I say this? You do not report multiple procedures with a modifier 51. You will rather report it with the times. Okay? So with path and lab, no modifier 51. No modifier 51. Rather, you want to do times 3, or times 2, or times 5, or times 10. Okay, that's how you want to report your path and lab. So we're going to start right out on page 450, the organ or disease-oriented panels. These are a group of tests that are often ordered together. You will see this as the basic metabolic panel, the general health panel, and the electrolyte panel. And you should follow some rules of panels. And it should be right in the paragraph right above 80047. All of your tests must have been conducted and be medically necessary. You should not conduct a panel just because. Do not use the modifier 52 for a reduced service. If there are additional tests that are over those that are in the panel, they would be reported separately. If all of the tests in a panel are not performed, then you would list each test separately. You would not use a panel code. So if, for instance, in 80047, the doctor wanted, calcium, chloride, and potassium, then we would code calcium, chloride, and potassium. We would not code 80047. Over on page 451, drug testing, 80100 through 80104. You would list the drug screening, the drug confirmation, and the tissue preparation services. For the drug testing, you would identify the presence or absence of the drug and the qualitative analysis. You would confirm that it was conducted to double check the results of a positive drug test. How would we do that? We would use code 80102 over on the next page. To confirm that a test has been conducted to double check the results of a positive drug test, you would use code 80102.
I'm confused on that.
You're confirming that a positive test was confirmed.
Is that automatic?
What?
Is that automatic?
It can be, but the doctor might want it. Just clarification. Did it get run? Yes. When did it get run? Yes.
Huh.
So what are you confused about?
No.
No? Okay.
I'm okay.
The chromatography, this is a procedure in which multiple drugs are identified. Some of your machines identify all the drugs present in one procedure. Others might actually require 2 or more procedures to identify 2 or more drugs. When you're coding drug testing, you want to code the number of procedures, not the number of drugs. Again, for drug testing, code the number of procedures, not the number of drugs. So 2 procedures to identify 3 drugs, you would code 80100 times 2. So if you have 2 procedures to identify 3 drugs, you would code 80100 times 2. If you have 1 procedure to identify 3 drugs, it would be just 80100. The drug testing does not identify the amount of the drug present. It will only tell you, is it present or absent? It will not identify the amount, just is it present or absent.
See that a lot? Oh, yeah.
Your therapeutic drug assays on page 452. These report the presence and the amount or the absence of a substance. When you're reporting the presence and the amount, this is what is called quantitative. When you report the presence and the amount, this is quantitative. And I say that because you're going to need it when you do your exam. Your material can be examined from any source. Your drugs are listed by generic names. So amitriptyline, the generic name is amitriptyline is the generic name for Elavil. If this is your specialty, you're going to have a PDR to help you with your coding. Your therapeutic drug assays also measure peaks and troughs. The peak is after the drug is given, and the trough is before the drug is given the next dose. Your measure peaks are used to monitor therapeutic drug for medication adjustment.
That's like the Coumadins and stuff.
Right. The evocative and suppression testing on page 453 in your CPT book. This measures the stimulating or the suppressing agents. The stimulating meaning evocative, calling forth a response. And you might see the TC component here. You will have additional services that might be your HCPCS codes. So a J code or a 99070. You will also have an E&M for the physician who might be monitoring the test. Consultations on page 454. Consultations are for clinical pathology. This is at the request of the physician. Consultations, clinical pathology. This is at the request of the physician. They might need additional information about the specimen, and the consultant will prepare the written report. You will have two levels. You will have limited and you will have comprehensive. Limited is without review of the medical record, and comprehensive will include review of the medical record.
Can you give an example of that one?
Let's say a patient comes in and they're concerned about cancer. So they've run a bunch of diagnostic tests. A physician can quickly look at just the lab report and give a consult. That would be limited. So just like a lab report.
Like specifics, like
Right.
biopsy.
Right.
Okay.
Whereas comprehensive, he would take the full medical record, look at all the diagnostic testing that's been done, MRI, biopsy, lab, ultrasound, watching the levels of the different platelets, that type of stuff.
Okay.
That would be comprehensive.
Okay.
Okay? So a limited, without review of medical record, would be just a quick glance maybe at a quick report. Looking, here I have this patient, I just ran these labs, can you give me a quick, that would be limited.
Okay.
Some more consultation codes might be surgical pathology. Your surgical pathology codes would be 88321 through 88334. Your surgical pathology codes are going to be used when the pathologist reviews slides, material or reports, or provides a consultation during surgery. And he'll basically report based on the specimen, the block, the section, and the cytologic exam. So surgical pathology, 88321 through 88334. Okay, 331, 88334, right? Some of the terminology you should be aware of with Path and Lab is specimen. What is a specimen? A specimen is a sample of tissue of a suspect size. A block is a frozen piece of specimen. And a section is a slice of a frozen block.
Now, would that be the same block?
Yep, it can be.
Okay.
Your analysis brings us back to the 81000. Your analysis, 81000. This is basically test on urine. How do they test it? They might use a tablet, a reagent, or a dipstick. What would be the reason for the testing? Pregnancy, infection, and what constitutes being tested for? Bilirubin, glucose. The equipment used for urinalysis could be automated or non-automated, with or without microscope, and you would code based on the number of the tests performed. Your chemistry codes, 82000 through 84999. Your chemistry codes are on page 479 and 480. So page 479 and 480 in your CPT book, your chemistry codes. These are specific tests on any bodily substances: urine, blood, breath, and feces. Most chemistry tests are quantitative unless specified qualitative. Keep that in mind. Quantitative means specific amount. Quantitative means specific amount. And again, I'm telling you that there's a question coming up, and it's going to be qualitative or quantitative. Some of the samples.
I'm sorry.
No, that's fine.
For the chemistry part, you said specific test something.
Urine, blood, breath, and feces. If the samples are from different sources, they would be reported separately. So if you had a sample from blood and a sample from feces, you would report those separately. If the samples are taken at different times of the day, that would be reported separately. Okay? Let's jump back to molecular pathology procedures, page 457 in your CPT book. Your molecular pathology codes, you have Tier 1, Tier 2, and Tier 3, I believe. Tier 1 procedures report the molecular assay. This is more common for gene-specific procedures, so such as breast cancer. Your Tier 2 procedures report the less commonly performed tests, analyses. You'll find less common.
Procedures.
Tier 2 procedures are on page 482, 462? That's what happens when I don't wear my
462.
glasses. So 462 is your Tier 2. These are your less common ones.
Where's tier 3? I thought you said it was a tier 3.
I was incorrect.
Oh, that's the first
Can you
mistake
believe
this
it?
year.
I
can't
doubt
believe
it.
Seems we can't confuse ourselves.
Crap.
I make many mistakes.
I know, I tried to say, did Sam have a baby yet?
Mm-mm.
Holy
That
cow.
baby's still hanging on to her ribs.
Ugh.
Hematology and coagulation, 491 in the CPT book. These are laboratory procedures that are based on blood. So you might see a complete blood count as a CBC or a white blood cell count as a WBC. These codes are divided based on the method of blood draw and the test that's being conducted. So hematology and coagulation, page 491 in your CPT book. The laboratory procedures are on blood. So you might see a CBC or a WBC. A CBC is a complete blood count. A WBC is a white blood cell count. The codes are divided based on method of blood draw and test being conducted.
So a test would be like a micro?
Yep.
Okay. And automated is how they're drawing it for automated?
They'll take and automate it.
What?
They will take and automate it.
Okay,
They'll put
they'll
it in
take it on.
Yes,
Okay,
they will.
okay.
They will draw
Do it
it,
after.
and then they can automate it or not automate it.
What, now why do they do either one? What's, like automated is?
It could be the way that they want the test to run, because when you're not automating it, it takes longer.
Okay, I see.
Your immunology codes, 493, 86000 through 86804. Immunology will identify the immune system conditions caused by antibodies and antigens. So this would be where you would see a hepatitis C antibody screening. Tissue typing would be your basic assay screening and typing. Those would be codes 86805 through 86849. So tissue typing, page 498 in your CPT book. What you'll see underneath tissue typing is the compatibility test on tissue, matching donor to recipients, and measuring and monitoring any cytotoxic conditions. So tissue typing, compatibility tests, matching donor to recipient, measure and monitor cytotoxic reactions.
This must have been a big one when they did that face transplant.
Yeah. Transfusion medicine, page 499 in your CPT book. This is where you will see the blood bank codes. This is where tests are performed on blood or blood products. This does not identify the supply of blood, but the collection, the processing, and the typing. Your microbiology On page 500 in your CPT book, this is the study of microorganisms. This is where they identify the organism and any sensitivity of the organism to antibiotics. So whatever reason we're calling ourselves. Microbiology caution. You will see that there are many code descriptions similar to those in immunology. The difference with microbiology and immunology is the technique that is used. So microbiology, what's the technique that is used?
Microscope.
Anatomic pathology on page 506 in your CPT book. This is where your post-mortem exams come in, your autopsies. This reports only the physician service. Your codes are divided on the extent of the exam and the type of exam. Is it gross versus gross and microscope? A gross exam is without the central nervous system. A gross and microscope is without the central nervous system.
Gross is without.
Gross exam without a central nervous system is 88000. So look at 88000.
Okay.
Gross and microscopic without central nervous system is 88020. So with your postmortem exams, these are both gross versus gross and microscope.
So is there one with central nervous system?
With brain and spinal cord.
Oh, on the index. Okay.
Cytopathology, 88104 through 88199. This identifies cellular changes. Cytopathology, 507 in your CPT book. This is what you'll find under this common laboratory procedure is Pap smear. Your codes under cytopathology will be type of procedure and the technique that is used. So what is the type of procedure and what is the technique? On page 509, cytogenic studies. This is the branch of genetics that is concerned with cellular abnormalities and pathologic conditions. So things such as chromosomes. So cytogenic studies is genetics. Then on page 510 in your CPT book, we have surgical pathology. This is the evaluation of specimens to determine disease pathology. All the tissue is removed during procedures and they undergo a pathology evaluation. And you'll see they have different levels. Your operative report usually is coded after the pathology report is received. The pathology report usually coded with the OR report. You will see in these reports the unit of measure. So this is where you can do ×2 or ×3 when they take the specimens. Some types of pathological exam, as I mentioned earlier, microscopic means with microscope, and gross means without microscope. So gross and microscopic means that they did it without the microscope first, and then they used a microscope. Now you'll notice on page 510 in your CPT book and going over to page 512 that there are 6 levels of surgical pathology, and they are based on the specimen examined. So for example, breast, prostate, lung, then the reason for the evaluation. So radical procedure for suspected carcinoma. So 6 levels of surgical pathology. First, based on the specimen examined, and then the reason for the evaluation. These levels are divided on the complexity of the exam. So the first thing is a biopsy. That's not too bad, right? Then we have a segmental resection. That's a little bit more in depth. Then we have a total resection. I'd say that's pretty intense. So your levels are based on complexity of the exam. And it tells you right by each level. Level 1, the specimen, gross examination only. So without microscope. Level 1 is without a microscope. Level 2, they're going to do a gross exam first, and then they're going to use a microscope. Levels 3, 4, 5, and 6, same thing. It's going to be a gross exam and then a microscope. An additional difficulty. The physician will have additional work. Pay attention to the method of or the need for removal. And you will find that the same anatomical site can be listed in each level. It just depends on what's being done. Is it a biopsy? Is it a resection? And that's it for 29. All right. Theory and practical at the end of chapter 29 in your textbook. Page 812, right? Or so. Number 1. You forgot it?
No, I just had my card, so I put chapter 28 on one side, and I would put chapter 29 on the other. I just lose it, don't know.
Okay.
Because I didn't do this chapter. I mean
Okay.
the question.
Number 1 is test or tests. Number 2, indicators. 3, organ or disease-oriented or panel.
Oh, I put the codes.
Okay.
I'm assuming that's it.
Okay. Four is no. And 5 is yes. Number 6, 85004 and 85032. 7, 88304. 8, 88302.
What was 7?
88304.
30. Yeah.
8, 88302. 9, 88300. 10, 84181.
84181.
Yes.
Where really?
11, 84597. 12, 82101. 13, 82930 times 3. 14, 83003.
83003.
15, 83525. 16, 83721. 17, 85032. 18, 85060. 19, 85730. 20, 85652. With diagnoses 780.60 and 729.81. 21, 85345. 22, 85280 with 627.0. 23, 86910. 24, 87086 and 788.1.
I got it right.
What was the first CPT code? 870?
86. 25, 87197 with 729.5 and 780.60. 26, 88007. 27, 80162. 80202 and 427.81. 28, 88329. Page 187 in your workbook, Path and Lab. Number 2, presence. Number 4, physician, supplied agent, or supplied agent, or agent. 6 is 6. 8, you should have 82550.
Oh, wait a minute, 6 is 6?
6 is 6.
Oh, okay. And 8 is what, 250?
82550. 82553. 84484. And
Doing this-
410.41.
Doing this, I turned the page and I saw all the numbers and said, I don't remember having to figure out all this stuff. And I'm going, what? Then all of a sudden it hit me. You're looking just for the CPT codes.
Yes. Yes.
And I just,
So write it on a separate piece of paper and you can go back and check it if you didn't do it. I know you all get frustrated when you get an incorrect code or diagnosis, but honestly, that is the best way for you to learn, is to write the correct code next to the one that is incorrect and go back and forth and look and see, okay, what am I missing here?
Mm-hmm.
That honestly is the best learning piece I can give you in this whole course. I can stand up here and I can lecture you until I'm blue in the face, but it's by our own learning of what we chose and why we chose it that we're going to remember it better next time. Because I'm giving you the resources, I'm giving you the tools. You're not going to memorize this stuff. That's why we're making all these notes in your books, so that when you go to look at them, you know, what you put next to a code, Bonnie's going to put differently next to another code, and Lori's going to have a different note next to another code, and so on. It's all in how we learn, okay? And I can tell you that every one of us will take that test differently. You all do your homework differently. You take your Evolve exams differently. It's just in how you learn. So if you can remember that this is where the learning really is going to be happening, so when you sit for that national exam, you will be so prepared it's not even funny. And I know you don't feel that way now, but when you get to it, you will have already had 3 simulations and we will have worked out the kinks, because you're looking at the incorrect code and the correct code and you're getting that aha, like, oh, that's why.
When doing this, the last test that I did on Evolve, okay, I was like, I'm never going to get through this. Never going to get through this. And I do those all the time, the test I was doing, you know, and it's like, okay, but my problem was I wasn't thinking, just use your CPT book.
Mm-hmm.
I was using this book too.
Yeah.
And it's like, all of a sudden it hit me. I took that book and I put it in
Yeah.
the other room, get it away. So I've learned on my test, just use your CPT books.
You should only be using the books that you're going to be sitting for the exam.
That's
all you're
all
gonna
of a
have.
sudden it came to me. It's like, oh.
In the beginning, you know, when you're starting out with the HIPAA and the compliance
Right.
and that type of stuff, you can use the textbook, but really rely on your CPT and your ICD-9.
Yep.
Because that's when you're going to learn from what you make mistakes.
Mhm.
Yes.
so I apologize, I have the, number 8,
Mm-hmm.
'cause you're,
82550,
yep,
82553, 84484, 84484, and diagnosis 410.41.
Thank you very much.
Yep. Number 10, 83735, 83540, 84100, and 84155. Your diagnoses: 586, 285.9, and 401.9.
480.9.
401.9. $12, 80198 with 493.90. Number 14, 493.90.
90.
Oh.
Number 14, 88305, 198.82, and 199.1. $16, 88305 times 3, and 211.3. $18, 88305 times 2, $211.3, and 530.85.
For some reason for that CBT code, I put 88305 twice. Is that acceptable?
Yeah. Number 20, 88304 and 214.8. Number 20, 88304, 214.8. Number 22, 88305, 707.04, 707.20. Number 24, 88304, and 704.41. 24, 88304, and 704.41. 26, 88104, and 518.0.
514.80.
518.0 for 26. So next week, chapter 30, and what time we have left, we will go review. And we'll get through as much of the book as we can for review. Bring your exam review books with you, please.
This stuff.
Yes, the red CPC Buck Exam Physician Review book. So either later tonight or first thing in the morning, I will try and get those review emails sent to you. If not, it will have to be late tomorrow afternoon. I'm going to an office in the morning, And if Evolve Chat is not available tonight when I get home, I'll let you know.
Okay.
But you can also try and register for that course as well.
Yeah.
Maybe I couldn't do it because I was logged in as instructor. I don't know.
I'll try with what you gave me for.
Yeah. All right, everyone. Thanks. Have a great week.